UNITY VCS is indicated for use during anterior segment and posterior segment ophthalmic surgery. Federal law restricts these devices to sale by or on the order of a physician. Appropriate use of system parameters and accessories is important, as improper use may result in patient injury. Please refer to the directions for use for complete indications, warnings, and safety information. For full important product information, please visit unityvcs.com. References and disclaimers related to topics discussed in this podcast can be found in the description.
We'd like to welcome you to RetinaLIVE. I am Kourous Rezaei, the host, partner at Illinois Retina Associates and associate professor at Rush University Medical Center. The esteemed faculty today is Dr. Lejla Vajzovic from Duke Eye Center and Dr. Aleksandra Rachitskaya from Cleveland Clinic, Kola Institute, Cleveland. So welcome. Today, the topic of discussion is Unity. And you know, this is a new machine that is becoming available to retina specialists. And it provides a significant surgical efficiency in many aspects of how we operate, you know, from the Unity HYPERVIT for the vitrectomy probe, the Unity Tetraspot for the laser, Unify for the gas. Then we have the Dynamic Stiffener for 27 gauge, and also next generation entry system for Universal VFC Canada. So let's talk about the cutter itself. You know, the cutter is the most important instrument for vitreoretinal surgery. And some of the advantages of the hypervitrectomy probe, one is the 30 cuts per minute. I think is the fastest vitreous cutter there is. It's a dual blade. The bevel tip design that allows you to get closer to the nerve, for example, when you use PVD, and also the dynamic stiffener for 27 gauge. So Lejla, how do you think, for example, the 30,000 cuts per minute would impact your surgery? What kind of cases do you think it would have the most influence?
I think it's going to have influence in all of the cases. First of all, it's going to make us very efficient, removing the vitreous, but decreasing the amount of traction that it's applying. You know, our most common cases are your typical retinal detachment. You're always concerned, especially in a teaching institution, how close is that cutter coming to the retina? Is it really going to pull retina into your port? And will you be cutting some vitreous and retina together? Well, you're definitely minimizing traction with this type of cut rate, at the same time removing it very efficiently. And then also just in the process of shaving periphery, you want to be efficient in removing, but not creating that much traction. So I think it's going to really help in every step of the procedure.
Aleksandra?
Yeah, I totally agree with it. And as you mentioned, the bevel tip is something that I really like. And not only for these, you know, bread and butter cases, but more complex cases like TRDs. I routinely do TRDs with just a vitrector unless I have to switch. And having the bevel tip and getting into those membranes and be able to, release the traction and is really helpful. I'm routinely these days a 25 gauge user. I find that 27 is, for me, in my hands, and in the hands of the fellows who are learning to do surgery, is a little flimsy. So I'm really looking forward to the stiffener because, once again, there's cases where it's a little bit more complex and getting access might be much easier with the 27 gauge compared to 25 gauge. And the experience that I've heard is that the 27 gauge with the stiffener now with the system is performing as good or better as the current 25 gauge. So I think that's kind of an exciting part of it. I think I remember when I was training, there were some people who were still using 20 gauge. And then, when I was a fellow, it was 23 and now 25. And there's some people who've gone to 27, but I just haven't seen the efficiency of it and the use. So I'm looking forward to the stiffener.
Yeah, I think the stiffener, is going to be a game changer for the 27 gauge. And I think one of the reasons we all went into retinal surgery was microsurgery. You have fine instruments, and the finer the instrument, I think, is the less iatrogenic damage you're going to induce just from the trauma of the surgery. And I think having finer instruments would potentially make it safer. And in addition to that, also the post-op recovery would be shorter. And one of the disadvantages in the past had been the flimsiness, as you pointed out, and also the efficiency that things take longer. And then my understanding is now with the new cut rate, with new flow rates, and also with the bevel system, your efficiency would be very similar to a 25 gauge. And I think in addition to that, it's a little bit counterintuitive that in the past, when you had the more complex cases, like a traction rhegmatogenous detachments in diabetics, you always thought, oh, I want to use a larger instrument. But it looks like with these instruments, you actually want to use the smaller instrument, for example, the 27 gauge. It allows you to be 40% closer to the tissue. And then, as you said, Lejla, because you induce less traction, it allows you a better dissection of this complex detachment, potentially even in a combined rhegmatogenous traction detachments. Usually in the past, when you had the combined rhegmatogenous traction detachments, you pretty much always need to do a bimanual dissection because of the suction. There was no counter pressure. But now, because you have less suction due to the dual blade mode of this system, that may not be necessary. And you may be able to use even a 27 gauge. What do you think, Lejla, about that?
No, I completely agree. I think both of you, what you brought up, Alexander, for example, just being able to use smaller gauge, using cutter more like your primary tool. We used to just use it for core vitrectomy. I think for me, the biggest advance has been this beveled cutter, where I really now saw a difference where I'm using the cutter really for all my steps, including the scissors, especially in the tight space and TRD. And I actually find myself 27 gauge beveled. It's really nice for those tight spaces and TRDs to be exactly precise in kind of lifting that tissue, sneaking in, and using as the scissors. And I absolutely love this for TRDs, but in pediatric retinal cases, you really want to be precise, not create any iatrogenic holes, and I prefer to be small to be as precise as I can.
Well, it's really interesting because sometimes these days people do combo. You set up for 25 and you use 27 cutter because, like Lejla mentioned, you can get in smaller spaces. So wouldn't it be fantastic that you don't have this, open extra things and have this cumbersome setup where you can do everything with 27? And the stiffener is on the cutter, but also on the light pipe. So as we operate with the viewing systems that we have, it allows you to move the eye and control the eye better.
Exactly. And that's exactly what I do, Alexander. I will do 25 gauge and then open extra cutter that's 27 to allow me to get to those tight spaces. But I am just, previously I wasn't happy with efficiency of 27. I wasn't happy with stiffness either for those gross maneuvers of tilting the eye, getting into periphery to shave and get rid of all the vitreous. And then when you're focusing on the macula, you don't worry as much like what the stiffness is of tool is. But now it's awesome to be able to be as efficient in 27 gauge and also have stiff instrumentation.
And I think the other thing I observed, I haven't used it a ton, but just in my experience utilizing it so far, also your cannulas, the entry system is a little different. It does go in smoother. In the limited number of cases I've done so far using the new system is I don't see the cannulas moving as much and coming out. And so I think that also, in addition to 27, is a good marriage, right? You need to have good cannulas that are easy to get in. We do a lot of re-ops, at an academic center. Patients who are very complex get sent in. Patient is previously vitrectomized and the eye is soft. You're trying to get in. So it's been really helpful in that regard.
It's interesting you mentioned that one of the things I hate during surgery is when the trocar comes out. I think because, the whole thing balloons up and then you have to go, and the last thing you want to do is to cut the conch, to find and so forth. And I think it's great that that prevents that from happening. And as you pointed out, Lejla, that the getting closer, I think with the 27 gauge now you get about 40% closer, with the 25 gauge 47% closer. So you get really close to the tissue. And with the 27 gauge, due to smaller size of the tip, that allows you to do a better dissection without sucking the retina, because the size of it, the sphere of influence is just smaller. And I think the 30,000 cut per minute dual blade would allow you also for the scleral depressed depression, even if you have rhegmatogenous detachment that prevents that retina to come into the tip. And again, because you use a 27 gauge tip, the tip is so small that before the retina jumps towards you, even if it does, I think you will still have the opportunity to walk away. So I think in general, I think hopefully it makes us all even better surgeons with allowing to have, as you said, the stiffener, to use the 27 gauge, have a higher cut rate, and also have a bevel tip, as you pointed out, Lejla, and also be closer to the surface of the retina. You want to point out something?
Yeah, I think also, it's not only the cutter. I mean, I think HYPERVIT and 30K helps, but also the way the system works, that is flow-based, you can actually get much closer to mobile retina. So it's really impressive when you have, bullous detachment, right? And you're removing the vitreous, and especially when the fellow is removing the vitreous, you're like losing, I don't know what kind of cells, heart cells, brain cells,
Both.
Both. But you always worry, and I think ability to have more stable retina that's not jumping all the time is something that's going to be also hopefully a game changer in the bullous retinal detachments, where before you clear the brake, there's just so much movement and you can control it better.
I like that for myself too, independent for the when it happens to me, I use those some cells when I eat a piece of retina.
Yes, yes.
Sounds great. And I think one other part, going back to what both of you said regarding using the cutter as the main instrument, somehow, I don't know, I generally like as a surgeon, if I had to choose, I like to use the cutter for most of the things. Usually when you end up using a scissor or change instruments, is because you cannot move anymore, you advance the case any further, or you're concerned you're inducing breaks and so forth. But if you be able to use the cutter on dissection and so forth, I think it also makes it a more efficient surgery. I actually like it personally better in comparison to scissors.
But I mean, if we think about efficiency of surgery, right? So we talked about vitreous removal, the key steps, generation of PVD, ease of entry, right? And as you pointed out, instrument exchange takes a long time, even if it's, you need to open it. You're deciding, am I going to open something else that I have to charge for, right? And waiting and then transferring. So the ability to do everything with one instrument is quite powerful, not in terms of only efficiency of the way it's, removing the vitreous in the eye, but all the other movements that you're making as a surgeon.
So I think we all agree, I think, that the combination of the stiffener, 30,000 cuts per minute, closer the bevel tip, and being also closer to the surface of the retina, and also being able to use 27 gauge, probably adds a fantastic instrument to our armamentarium, both for those of us who train fellows or even for ourselves to do complex or simple cases. So I'm going to move on now from the cutter to the laser probe. And generally, from my perspective, the most boring point of the retinal surgery is to do laser, because you basically do the same thing over and over again. And either for diabetics, I usually like to laser all the way to the aura scleral depressor. That takes a lot of laser spots. And even in detachment, I usually like to do 360 laser. And again, that takes me some time, 5 to 10 minutes, to just do the same procedure one by one. And now we have the tetraspot available to us that allows you to potentially do 2 or 4 spots at the same time. We did a little in-lab experiment to see how much more efficient it makes you, and it makes you almost 3 times more efficient from time perspective. And for me, when I was doing the experiment, going from 4 spots to 1 spot was such a painful experience, because once you, oh my God, this is so much better, and now I have to go one by one and spend another 10 minutes to do the laser. What has your experience been, Aleksandra, with the tetraspot laser?
Yeah, I think it's not my quote, but one of my colleagues says there's nothing, that is a little painful than watching a first year do the first laser, right? Because it just takes so long. You're almost done with the case. You've done all the kind of, cool parts, and now you're waiting. I think the ability, so what I like about tetraspot is that you don't have to use it as a tetraspot each time. You can use 4 spots, you can do 2 spots, you can do 1 spot. And I like that there's a light, because I like using light on my laser and have illuminated laser. It does take a little bit of time, I think, to learn how to use it optimally, because you kind of have to rotate it and figure out so your distribution of the spots is exactly the way you want it. But especially, and for instance, for tears, for retinopexy, I use continuous. So I might use it for something like that, but to your point, for PRP, and if you go 360, those where you have to cover a large area, I think it's a great option. And I would suggest that if somebody is starting to use it, maybe start with 2 go from 1 to 2, get comfortable with 2, and then try 4. Because I think when you first get it, you're like, I'm going to do 4 right away. And I think sometimes because we're not used to doing it, you might not like it as much. So go from 1 to 2 and 2 to 4.
Lejla?
Yeah, I couldn't agree more. That I think this is one of my most favorite feature of all of these updates and upgrades, and with the new system, I think TetraSpot, there's nothing that pains me more than like starting fresh with a first year fellow and watching them, like it was mentioned, laser. And this is definitely going to be all making us all more efficient. I think also like helping those who are starting off be really efficient, because time in the eye matters. These are often diabetic patients, not often, they're mostly diabetic patients. Timing the eye, the pressure, elevation in the eye, systemic, like there are a lot of factors that can unfortunately lead to ischemia of the eye because of the duration of the procedure. And however we can influence to cut down the time that we're spending in the eye, I think is beneficial for the patient. And then what Aleksandra mentioned, I love the fact there's a flexibility. If you prefer 1 spot, you can choose that. If you prefer 2, you can choose that, or 4. And then depending on what the pathologies, I similarly love the continuous laser option, for inferior retinectomy, for tears. You could actually continuous with this with 2 spot, and you just get 2 rows right away. So I just can't, absolutely, like, really efficient, and that really helps. Yeah.
So I agree with your comments, and going back to what Aleksandra said. So I tried the 2 spots, and then after a few 2 spots, I went to 4 spots, and I never went back. I just did that. And I think just a very important point that you brought up regarding the amount of time spent in the eye. I think in general, you don't want to do any shortcuts. You want to be efficient, but you want to spend the minimal amount of time, because the longer you spend there, things can happen, as we all know, over time. And then going back to what you said, Aleksandra, it's great that you have optionality. If you don't like the 4 spot, you can go still to 1 or 2. And it's a great point to start stepwise. One additional tip I can give that may help adapting to the 4 spot is also to decrease the spot interval, the interval duration, so that you're not quick enough to move, and maybe go a little bit slower till you get used to it, and then move on. And go ahead, Lejla.
And it was mentioned, and Sandra mentioned lighted laser probe. I absolutely love operating with lighted option. I'm so glad that this comes with a lighted laser option, because it really is helping us be independent. And while you're depressing and visualizing the tear, you want to encircle in right away. So it's really helping us teach the next generation to be independent, because most certainly they are not going to have, the professional assistant that I am sitting next to it at all times. So, yeah.
And I think nobody is a better assistant than yourself. That is, I think, no question about it. I think you are the best.
Everybody, exactly. You know exactly how you want to move, which direction you want to move. So if you can do it yourself, that's the best option.
And so I think and that's why I think it's an engineering marvel in general, because having a 27 gauge, it's such a small size, being able to add, as you pointed out, the lighted probe. So it's a lighted probe, it's curved, and the curvature is actually very easy to get in and out. And at the same time, when you put the 4 spots in, all 4 of them take, and having the optionality to do 1, 2, or 4 spots. I think that gives you a lot of flexibility and optionality to surgeon, I think. And then at the end of the day, being shorter, more efficient timing that you cut your PRP into, I think it makes a big deal. So I think that's another great advantage of Unity. And the 27 gauge is as efficient as the 25 gauge, and I think that is really important. So now you are both in academic setup, and many times people do both cataract surgery and vitrectomy surgery. And I think, as we all know, the staff are not always trained to do both machines, set both machines up, and so forth. So obviously this machine provides also a phaco system for those of you who do combine, or actually have a cataract surgeon in your institution who does cataract surgery. How do you think this impacts the efficiency in the operating room, Lejla?
Well, I can tell you that I loved the machine, but my staff loved it even more. Why? Not only was it easier it's much lighter, it's easier to maneuver in terms of all of the setup. It's much more streamlined in terms of the design. So they really almost enjoyed wheeling this around the OR. I mean, it was really light. And like you mentioned, we do quite a few combined cases. I'm fortunate to have amazing cornea faculty who are operating next to me every time I'm in the OR. So we tend to just, hop into each other's ORs and help with whatever steps are needed. They need help with the drop lens. We're right there. It's vice versa. We schedule purposely combos cases to help us. And in those situations, we are now dealing with setting up currently 2 machines, Constellation for my procedure, and then, whatever the cataract surgeon preference is to have there. So there are 2 machines being set up. So 2 efforts and different, packs that are being opened. All of that takes time. In addition, imagine how crowded the space is around the patient, and us maneuvering and switching out seats is it's interesting dance we perform for sure to get all of that done. So having one system that does it all, one setup, first of all, it's already streamlined setup, it's lighter system, and having it all at the same time.
I totally agree. When you allocate the time for combo cases, they take longer than if you did 2 separate surgeries, right? It's just the case. And I always say when you operate, devil is in details, and small things like, I don't know how you guys do it. You set up and they're moving the machine up. Okay, we need the circulator come to push from the back. So it's takes 10 people to move the machine right now. And with this machine, you just need 1 person, so you're not dependent on other people. And just like as Lejla mentioned, we also have to bring 2 machines, 2 setups, and then when the cataract surgeon is done, you're switching everything, and that takes time. And it's so unnecessary, right? If you think about it, there's nothing of benefit to the patient in case, if anything, the cornea is getting drier as you're waiting for that switch. So it's, I think it's really going to be beneficial to bring it all in one. And I think our cataract surgeons would also appreciate, because they're very busy, and so they try to come to your room for the shortest amount possible, right? Shortest amount of time possible. And I think that will only help the collegiality and working together.
And I think they also feel more comfortable because this is the machine they're going to use to do their phaco anyway. So it's not like you're changing the machines, moving things around. And I think Lejla pointed out the most important thing, which is having your staff be happy. I think that your happiness doesn't really matter as much, but if your staff is really 100%. Happy, so they don't worry if you're doing a combined case or if something happens. And it goes, I think, both ways. If they're doing a cataract surgery and it's a drop lens, and they call you in, and if you want to go and do something at that time, the machine is already there, is already set up, and the staff is already trained in setting up that machine.
But what you pointed out, anytime there's a drop lens, and if we're helping, that takes time to pull in another machine, set it up. But not only you can staff gets a little anxious, are they really feeling comfortable maneuvering that and operating that machine? So all of those factors play a role in really having one system to train everybody on is going to simplify everybody's life, because it's going to be one for all.
And one additional topic that I thought we may want to touch upon is, the performance of the vitreoretinal surgery with the new machine. It gives you a better fluidics, intelligent IOP, the intelligent aspiration, and also the illumination. Lejla, do you want to comment on any of these?
Yeah, I think all of those are really amazing new additions. I think, first of all, I'm extremely excited about intelligent IOP. I think all of us will love that feature and will continue to love it. Why? Because there are times that, we're not quite pressurized in the eye, or there are times we're adding fluid, and we always think about decreasing pressure, being mindful of using instrumentation that at the same time it's allowing fluid to escape. Now you actually don't have to worry about it, because there's intelligent IOP. It's controlling for pressure inside the eye. So if you're adding fluid, there's going to be some egress of fluid through the infusion to allow for, steady pressure, whatever you set it at in it. So that makes, for example, adding fluorocarbon, adding gene therapy, adding silicone oil easier, because you don't need additional vents or additional steps to allow for equalization of pressure. The system is allowing you to do that. Similarly, you may, when you're doing fluid exchange, sometimes, for example, you'll maybe in the fluid, but you escape into the air. And I see that often with, our trainees, especially when they step down in the pedal and they're aspirating air. And then there is times, especially if it's a highly myopic eye, there is a little bit of collapse of the eye itself. And I always worry, I was like, oh gosh, are they like close to the optic nerve on the macula? Are they going to like now touch the back part of the eye because the eye just collapsed a bit? This is really allowing for all of those differences to not exist anymore, for the pressure to be constant.
Aleksandra.
Yeah, I mean, I couldn't agree more. I think IOP is such an essential part of a successful surgery. You don't want to be too high, right? We're always watching the nerve. And, when I operate with fellows, they're so focused on whatever task they're doing, especially early on. They're very single, task oriented. And I'm looking for everything else that could be going on. I'm looking, is the eye collapsing? Like Lejla mentioned, you can start seeing it. Or is the nerve pulsating? So the pressure is so important. And having that under control is key, because you could be, the surgery is not over until it's over, and you could have a beautiful surgery and then use diabetic surgery, and then you get hypotony and it starts bleeding, and like the whole thing can become more complicated than it was a second ago. So I think the intelligent IOP control is a key feature.
I think Aleksandra just made an excellent point. She's the one very observantly watching what's happening as, she's teaching somebody to operate, what's happening with the, pulsation of the nerve, what's happening in terms of corridors forming or not. We're kind of like, taught to like observe everything else that is happening. But somebody who's starting off, and even somebody who's experienced, you can't observe it all at the same time.
I think you both make great points. I think this, in my opinion at least, over the past 20 years, these machines make you better surgeons and also make surgery easier. It's very intuitive. And again, you many times pointed out you're working with the fellow, but even if you're operating on yourself, as you pointed out, Lejla, you cannot pay attention to everything. And then you try to be as diligent and vigilant as possible that every little change, this is going to happen, and your mind goes, okay, the 3 next steps, things are going to happen, and try to predict and avoid. But many times, it makes the procedure a lot more relaxing and a lot easier when you have a machine that provides you a safety net of if the eye is getting soft, or making sure the retina is not jumping into your retina, or you don't have bleeding, and so forth. So I think our time is coming to an end. So what are your final thoughts if you want to summarize the advantages of Unity for vitreoretinal surgery? Aleksandra, I'm going to start with you.
Yeah, I think it's really neat because it's not one thing, right? And I think it's the way that the new features, just like the ones you mentioned, the cutter, the flow-based system, the IOP control, the tetraspot, the ease of entry, it all kind of it has the effect is like multiple, right? It's all contributes and builds on each other, and I think it's very exciting. The stiffener, it's very exciting. To Lejla's point, I think the first question you asked to Lejla, when are you going to use it? And the answer is probably in all of your cases, right? Because I think it's really I appreciate the engineers who really are behind all of this and kind of thinking through where are the gaps and how can we improve this.
Yeah. And I think Aleksandra hit said exactly what I'm going to echo and agree, that I think multiple features are making this system really special, and special in the sense that it's going to make us more precise, more efficient.
Great. I think it was Sir Belfort that said your perfection is a goal, and it is really important to pay attention to details, and little by little, when you add these little things together, would make a gigantic leap. You're not going to do from one to the next at once. And in addition to that, also helps training the next generation of retina specialists. So again, you make my job so much easier, having fantastic faculty like yourself here participating. Thank you for sharing your expertise. And I'd like to also thank Alcon for putting this session together. Thank you.
Thank you.
Thank you.
UNITY VCS is indicated for use during anterior segment and posterior segment ophthalmic surgery. Federal law restricts these devices to sale by or on the order of a physician. Appropriate use of system parameters and accessories is important, as improper use may result in patient injury. Please refer to the directions for use for complete indications, warnings, and safety information. For full important product information, please visit unityvcs.com. References and disclaimers related to topics discussed in this podcast can be found in the description.